Urology is a techno-driven specialty. Urology has always been in pole position to try new technologies, from the early days of laser to laparoscopy, robotics, and I would say that AI is not an exception and finds a perfect fertile ground in urology. The potential application of AI are countless. We're talking about from image recognition, like in pathology, radiology, to the prediction of the region of interest and therefore tumors, as well as, for example, the early days of generative AI for I would say reducing the workload of physician. So what we used to say is that AI is here to stay, but for now, at least, it will not replace urologists, but those of us who will use AI will replace those who don't. So now, in terms of AI, we have to distinguish between, I would say, three main different things. The first one is how AI can improve patient care, how AI can help physicians in reducing the workload, keeping the workload, and improving the performance. And the third one, how AI can actually embrace patients in getting more information about the diseases and not falling in the pernicious trap of the fake news that on the internet is always around the corner. So, talking about that, Liam, myself, Kevin Zorn, and the team, over the past, I would say, 6 months, we started this, review of the evidences on how AI can be used for, improving patient care for patients with BPH, BOO, and of course the treatment related to that. And Liam now will discuss each one by one those potential applications.
So thank you, Dr. Cacciamani. As you mentioned, we had done this review and we sort of identified five major domains about how AI is incorporated into medicine and more specifically BPH treatment as a whole. So those five domains are the diagnosis of disease. So for example, differentiating BPH from prostate cancer is like a big area of interest. Additionally, diagnosis like on a histopathological level, imaging diagnosis, symptomatic criteria that are going to assist in diagnosis of BPH. All of those things are sort of relevant to a clinician, to a urologist when it comes, to making a diagnosis of one thing versus another. The second one is patient management. So for example, how can an AI, guide a surgical choice for BPH treatment? And there have been certain models which have had the goal of stratifying patients into different risk or categories of severity of disease, which would guide surgical or medical management. Additionally, patient management, one of the areas of patient management is also medical therapy optimization. A lot of patients are on 5-alpha reductase inhibitors or alpha-1 agonists, which are essentially like the mainstay of treatment. And some of them are on it for sometimes these medications are overprescribed or underprescribed depending on the patient population. And so, AI can help guide that as well. Surgical optimization is the third domain. So how has it been used intraoperatively? There was actually one model that we looked at that we read about in the literature that interpreted cystoscopy images. The AI model was able to show better accuracy for tumor detection than the actual clinician in this case. The fourth domain that we looked at was treatment response prediction. So, which models were performing the best for predicting therapy outcomes? That's all extremely important, especially when you're concerned with, prescribing medications accurately, not overprescribing, not underprescribing, not intervening too intensely on a patient, surgical wise. And these are all very important things that these models aim to address. And the fifth thing, which is one of the things that Dr. Cacciamani mentioned, is workflow optimization. So how can AI improve clinical efficiency? Like ChatGPT is like a huge thing now. Everyone's looking things up on their phones. Sometimes there's good information, sometimes there's bad information. And I think it's really important that, we make an effort to really, wield these tools wisely and implement safeguards so that people don't get the wrong idea. And that we can use these tools and parlay them into something that's extremely productive.
So from the data that we've collected and in this publication, kind of an up-to-date of where we are, where we're heading toward in the field as a urology society of how do we take all this data for our patients and help interpret it? How do we predict what the best treatment's going to be and help counsel, to the patient what their expectations are and help them make better decisions or have realistic expectations of an outcome. So you see the 5 domains and the diagnostics, which I think that is a huge area in capturing data. How often someone's urinating a 24-hour diary, bringing in some of the wearable, soundable devices that are listed for uroflows, getting the IPSS, seeing changes, prostate volumes, PSAs, getting all that hunting, gathering, putting it into something digestible in a short paragraph or two. That I think that's going to be a huge component of back end scavenging, bringing to the physician something that's going to be trends. You can see something's moving, something's not doing well, predicting and hopefully getting involved earlier in men's BPH therapy before they hit the wall, they get into retention, they have a catheter, they have an infection. These are sort of end disease, states where we have deconditioned bladder and what have you. So being able to get earlier diagnosis, getting in earlier, I think that's going to be a huge component with a smaller, stable workforce and a huge number of patients that we've got to take care of. So AI is going to help in our workload to capture that, get better information, not just a sort of 10-minute encounter. How are you doing? Here's an IPSS. That's minimalistic. We got to get deeper and see the changes. And then in the predictive elements, hopefully we'll see, as we can pick apart imaging so we can get some MRI data and have the AI look at the data within the pixels and seeing, hey, this is a very dense tissue prostate. The angle of the urethra is very steep. Maybe certain types of steam-based or stents may work or not work as well. I think that's going to help us predict. And then as we get more and more patients, we can then compare that individual to maybe a cohort of men with similar parameters to see, hey, if you went this way, these are going to be your outcomes. This may be your durability versus, another type of technique. So you can do more A and B testing, real world data evidence that can then, the patient can counsel beyond the encounter with a physician, which is limited. So if we have something that kind of 24-hour 7 shop that the patient can come back to and ask questions, how am I going to do with their proprietary personal information? It's safe, secure, what have you. I think that's going to be our next step of guiding patients through their BPH journey, making earlier decisions, making decisions at the time that's relevant, what's best for them, and help perhaps in the follow-up. That's nothing we don't even talk about. In oncology, the amount of follow-up is very rigorous. It's clear, it's cut, it's discrete. For BPH, what is it? Do we really have national obligatory guidelines, or is it, well, just return to your family doctor or return to us if there's a problem? And we know there are retreatment rates, both medical and surgical. So that's another thing. Well, what's the expectations as we move into the next decade of life, if there's regrowth or if it needs to be retreatment? And that's going to be another whole other area of discussion. So I think AI is going to be our butler, our assistant, our guide that's going to help us gather, and also to the patient, their back end, their reiteration, because patients come to meet with us, they may not remember everything that was said. So maybe help captivate, interpret, bring it down to a level of language and many different languages of their choice that help them understand, help make that a better decision. So I think AI, we're in kindergarten, we've got many more years ahead. The processing speed, the amount of stuff that we have, ChatGPT 5.0. What's next? What's in the next 10 years is going to be mind-blowing. So I think lots to think of, and I think we all have to welcome it. And that's why I think we choose urology, because we are interested in data, information, and new technology.